So I'll bring up a couple of comments. So there have been some other studies that have shown that we pick up our smartphones or iPhones over 100 times a day, right?
I
And
believe it.
so,
Sure.
I had a patient tell me, well, that's for the people who actually put it down, that just don't sit there scrolling, scrolling, scrolling. Hey, thank you everyone for joining us. This is clearly I'm Dr. Phillip Brunson with Man Eye Institute, and this is part of our podcast series for interventional ophthalmology. In this segment, we're going to focus on cataract surgery. And in interventional eye care, what we're really focused on are surgical techniques and options to help eliminate patients' need for glasses, contacts, and even medications in some instances. And today we're fortunate to have eye surgeon Dr. Brian Wright join us. Dr. Wright, thanks for joining us.
Thank you for having me. I appreciate it.
First of all, when did you join the Man Eye Institute medical team?
I joined in like 2011, so I've been here for about 14 years. Time flies. It seems like not that long ago, but yeah, 14 years.
It does fly. And so I won't hold you this, but if you had to ballpark about how many cataract procedures you've done in your professional career, what would you say?
A lot. No,
Yeah.
so like around 2005, I started doing surgery and training. So now I do about 2 to 3,000 a year, but I was not always that busy. I'm a lot different
Yeah,
surgeon now than I was
sure.
in 2005. And so I had to guess somewhere between 10 and 20,000 is my guess.
Okay. So I think we have the right guest for a segment on cataract surgery. That's perfect. So, well, I know all of us as providers, when we see patients, we'll diagnose a patient with cataracts, and then the explanation of exactly what a cataract is to a patient. Do you mind walking me through your explanation for a patient on that?
Sure. Yeah. Whenever I see a patient in clinic, I have this little placard I pull out that I go over cataracts. It's basically your natural lens is clear when you're born, helps you focus light so you can see. Over time, that lens goes from clear to cloudy, typically just from UV damage throughout our lives, just age, but different things can cause it to happen sooner. But regardless, the end point is that that lens has gotten cloudy. It doesn't focus light like it should. You start to get cloudy vision. You start to need more light. You can get glare with lights like headlights, night driving, that kind of thing. And so when that lens is no longer helping you, it's hurting you, we definitely want to take it out. And so we take out that natural lens and replace it with an artificial lens.
Okay. I feel like there's a missing. Patients think a cataract's like a film or like a growth over the lens versus the lens actually becoming just aged, if you would. So,
Yes, I hear that all the time. That can't you just remove the opacity and leave my natural lens? And
right.
no, the whole thing's turned cloudy. And so the only way to fix the problem is a surgical fix to totally remove the lens and put a new artificial lens in.
Okay. Uh, and then misconception patients have a lot is, you'll diagnose a patient with cataract surgery and they'll say, well, is it ripe enough? So I hear that probably every day in practice. So
That's very
when
common.
is when is a patient's cataract surgery ready or cataract ready for surgery?
Sure. So what I always tell patients is, that term is kind of probably from back a long time ago when cataract surgery used to be a big deal. It used to be a hospitalization, sandbags on the side of the head, no moving, that kind of thing. And so there's always for any surgery there's a risk versus reward kind of setup, and if the risk is not worth it, you shouldn't do it. And so back then, the cataract had been pretty bad, like you can't really see so much at all before you'd be willing to do surgery. But things have changed. Technology has led us to do much faster, much safer surgery than we used to. Now, my surgery takes less than 10 minutes. We just give oral medication to relax, just numbing drops. You just look at a light. You can use the eye immediately afterwards. And so that ripeness term is not as important. So what I tell patients is that we do this surgery even electively now for folks who want to get out of glasses. And so we wouldn't do that if it wasn't safe. Um, so as far as ripeness, I think that's more like an insurance type term saying, is this cataract bad enough that insurance will help us some? And for me, if a patient says, should I have surgery? I said, do you want to see better? If you're seeing good enough, then you don't have to do surgery yet. Or if you want to get out of glasses, then maybe it's time to do surgery. But cataracts is not cancer, it's not harming you. It just limits how well you see. And the end result's going to be the same whether I do it today or if I do it 5 years from now. And so I always tell patients, don't worry about how ripe or how dense this cataract is. What you need to decide is, am I seeing everything I want to see the way I want to see it, or do I want to see better? And if the answer is I want to see better, then let's talk about surgery.
Yeah. No, yeah, I 100% when I speak to a patient about it, I'll, are you bothered with your vision and, are you happy with how you're seeing? And the beauty with cataracts are you don't have to live with cataracts that are impacting your ability to see to drive at night. You can get it taken care of.
Correct.
Um, we know innovation in ophthalmology, which is one of the things I'm sure you love about the field of eye care and myself as well. But there's so many options for patients to help improve their quality of vision and really quality of life with cataract surgery. So some of the basic IOL options that now that patients know they're getting an implant for sure, right?
Right.
So what are their options to kind of look at once you've diagnosed them with cataract surgery?
Sure.
If
So
any cataract surgery, I'm sorry. Yeah.
yeah. So yeah, whenever we see a patient for cataracts, before I even go in the room, they've already got testing because I want to know how healthy that eye is, and also like how much astigmatism they have, et cetera, because different lenses are helpful for different people, and sometimes patients come in wanting a specific lens, and that's okay. But what I tell patients is, I've done a lot of these and I've kind of seen the, patients going in and coming out, what the outcomes are. And so you don't really have to concentrate on the lens name or whatever. You just have to decide what you want your vision to be afterwards. And we kind of simplify that here at Man Eye. We kind of have three categories. And so the first category is what we call just kind of basic surgery, where we don't use the newer technology. We don't use the laser. We don't attempt to get rid of all the astigmatism and all the prescription. We get that old lens out that's cloudy, put a new one in that's not cloudy, and then your vision will improve. But you'll probably have to wear glasses for distance and up close, and that's fine if that's what you want. Now, the second category, we we get rid of their astigmatism, get rid of their prescription. And so, like, if you look at your glasses, there's like three numbers on your glasses prescription, and we want to make all those as close to zero as possible if you're going to see well without them. And so we have the ability to get rid of all that prescription and astigmatism and give you good distance vision. So that way you don't need expensive prescription glasses. All you would need is dollar store readers. And I say basically, if you can touch it, if it's arm's length, then you're going to need readers for it. And then the third category is an extended range of vision. And with that, our goal is to make you as glasses independent as possible. And basically these lenses are splitting light to give you a distance focus, kind of a computer intermediate, dashboard, mirror, that kind of focus, and then a reading focus. But nothing is like your 20. And so these lenses are great. If there's a shortcoming, I tell patients, really fine print, like reading a pill bottle, or if it's really low light, you still may need a reader. But the goal is to make you uh, glasses independent as possible. Hopefully that's all the time, but at least as much as we can.
Okay. Well, I was just looking. We just completed one of the modern IOLs for extended range that you were just talking about. A study that's waiting for publication, one of the newest version ones, and 98% of patients were 20/25 or better. 92% of patients were 20/25 or better up close. So basically, about probably 92 to 95% of patients are glasses free for a majority of their day-to-day activities. Would you agree that's kind of what you see for the most part with a lot of
Yeah,
these
for
patients? Yeah.
sure. I think these lenses are really great. No lens is like your 20, but they're really good at what they are. What I also tell patients, the good news is everything's changeable and modifiable. So if you're not exactly where we want you to be, we can always adjust the prescription afterwards. Or worst case, if you just don't like the vision that you have, we can always exchange those lenses for a different type. And so, not that so I do over 2,000 of these a year, about two or three times a year I'll switch it out. So it's really rare, but we have that ability, we have that skill to change things if that's desired.
Okay. Well, so I'll bring up a couple of comments. So there have been some other studies that have shown that we pick up our smartphones or iPhones over 100 times a day. right?
I
And
believe it. Sure.
I had a patient tell me, well, that's for the people who actually put it down, that just don't sit there scrolling.
Right.
Um, so I think there's an idea that, hey, I just want great distance vision, and I'll put on readers. But if you really think about how much of your day to day world is up close within arm's length, two things: it's a huge inconvenience to put on readers. So if a patient has a healthy enough eye, they have that option. But then there's about 5 years ago, and I've got a study right here in front of me that was talking about not just the inconvenience, but the safety profile. And
True.
for years, I was putting patients in multifocal glasses that, after cataract surgery, that not really even thinking about the risk of wearing progressives and
Mhm.
walking downstairs or something of that nature. We all lose dexterity. There's this other thing that through our lifetime that we lose is called proprioception, which for patients out there, that's where weirdly we lose our mind's ability to communicate with our feet and hands and knowing exactly where they are in space diminishes. So you can imagine stepping downstairs and trying to know exactly where your foot is and stepping down and add in maybe arthritis or some of that nature, and then throw in multifocal glasses that are really throwing off the stairs on how you see. So it's actually been shown that it's a safety issue. I'm sure you've seen this, Dr. Wright, as well.
Yeah.
So
Yeah, for sure.
it says that older adults with multifocal glasses are 2.3 times more likely to fall than those in single vision glasses or not wearing glasses at all. And that falls directly account for 40% of all elderly admissions to nursing homes and long-term care facilities. So as much as we want to talk about the inconvenience of our phone, there's a safety issue with having that long range, extended range of vision as well.
For sure. And
Um,
so, like, two common misconceptions now that you're saying that is one, lots of times patients come in nearsighted and they're like, oh, I don't need help for up close. I just need you to fix my distance. And if you don't put in a multifocal lens, then just realize when you take the cataract out, you're hitting the reset button on somebody's vision and their prescription. And so just because you saw up close before doesn't mean you'll see up close afterwards. And sometimes it's hard for patients to understand that. And so I said, if you want to keep that up close, but also gain distance, the only way you're going to do that is with a multifocal because nothing else lets you do distance and up close. The other misconception is they're like, I've heard patients say, I don't want a multifocal because I don't like progressives. I don't like trying to find that spot and the dead spots with the progressive lens, etc. And so I said no, it works very different optically because just like that study says, when you look at the bottom part, trying to look at a stair, you're looking at you're having a near focus when you really want that distance focus, and nothing in your eye can do that because you're always looking at what you're looking at. And so these lenses inside the eye work different optically than what glasses do. And so I always say, no matter what you did with contacts or glasses, what we're putting in your eye works different optically than all of those. Because even multifocal contacts are okay, but they're not great because those work different optically also than the lenses that we implant. The lenses that we implant are much better than the contacts because those contacts are soft, so they can't etch those designs into them like you can a lens that we implant inside the eye. And so I always let patients know what we're doing is totally different than glasses and it's totally different than multifocal contacts.
That's best way you could put it. So you kind of already described a little bit. So if you were to describe a patient's expectations for the day of surgery, from what I've seen, there's always a lot of apprehension before the first eye, and that's another thing to bring up, right? They do insurance requires us to do one eye at a time a lot of
Right.
times, but then once they've been through it once, there's so much less stress involved with it because they know what to expect on the second eye. Do you mind walking through kind of patient expectations there?
Sure. Yeah. And so I tell patients they'll be there hopefully on my days, hopefully they're like an hour, but worst case, like 2 hours. And not because the surgery takes that long, just you have to fill out paperwork. You have to be hugely dilated because I have to work through that pupil and want that pupil as big as possible, which takes a little while. But when you show up, you'll do paperwork, etc. They'll give you medicine to relax, and so just stuff orally. We don't do any IVs or anything like that. And so get your oral medication, get relaxed. We give you numbing medication, so you shouldn't have pain. once you're actually in the surgery, you're basically just going to see a bright light. That's it. I tell patients the numbing drops are the same ones we use in clinic. They sting for a second, then you shouldn't feel anything after that. And really, you just look at a bright light. As soon as the surgery's over, you can sit up and use it. It's blurry, don't get me wrong, but it's good enough that you can see to get around. And then by the next day, lots of patients are seeing well enough to drive. I tell patients that's 100% up to you, because legally, as long as one eye is seeing well, you can drive. So if you feel comfortable, you feel like your vision's good enough, you can drive yourself the next day.
And then if you had to talk about the recovery, patients are worried about their limitations for that first week or two afterwards. What do you tell them at that point?
Yeah, so I say, things have changed a lot since we don't use stitches, and it's a pretty quick procedure. So what I say is really the same advice I give for LASIK. I say the same thing. I say, don't rub it, and keep it clean. So that means don't do anything as so strenuous that you sweat. Don't get in a pool. Basically, just keep it clean and don't rub it. And you'll sleep with a shield, so you don't rub your eyes in your sleep, because when you're asleep, you don't know what you're doing for a week. And so just kind of take it easy. You can work, you can do most of your activities, just nothing really strenuous. Keep it clean and don't rub it.
It's perfect. And then this is kind of a matter of semantics, but I guess because patients are out there, there's what's called a custom lens replacement and cataract surgery. And I know I've had patients say, well, what's a custom lens replacement then versus a cataract surgery? And you want to, I'll let you answer that one, Dr.
I'm
Wright.
guessing you're talking about like a refractive lens exchange yeah.
Yes,
So
yeah.
there's tons of different names for it, but basically what they're saying is we're not using insurance for this, or we're doing it electively to get out of glasses. And so the surgery is the exact same mechanically, that we're taking out the natural lens that you were born with, putting in an artificial lens. The type lenses we use are sometimes different. If someone just wants basic cataract surgery, that's fine. If someone's doing this electively to get out of glasses, you'll have to use a multifocal lens that will give that range of vision the patient desires. And we can do both eyes the same day. Insurance won't let us do that, but if we're doing electively, you can do both eyes the same day. And we kind of treat it almost like you're two separate patients, that we do surgery on one eye, they undrape, we get whole new instruments. So everything's different for the two eyes. I mean, I'm trying to think the last time I had an infection. It was probably 8 years ago or something. It's been a long time, but God forbid if you're going to have one, you wouldn't want it in both eyes. And so we always treat a patient like two separate patients when we're doing both eyes the same day. So that's sometimes a patient's safety concern. Is it safe to do the same day? And the answer is yes, that it is. We treat it, even though it's not separated in days. It's separated on how we treat each eye individually.
So, interestingly too, it's not there yet, but in some states they're actually starting to let, insurance approved cataract surgery have both eyes same day, just because two things, it's a major inconvenience having one eye done and one not. And they've also proven the safety profile of this surgery and efficiency is there, that it's actually the best care for the patient to have both done as soon as together as they can. So,
Yeah, I know California, the big
Kaiser or
Kaiser, yes,
Kaiser, yeah. Mhm.
has been doing that, and I, like you said, I think they're looking at it now, so we'll see.
And then last but not least, the maintenance for this type of surgery. So patients will say, well, then when will my vision change again? I get asked that a lot. Or what kind of maintenance is associated with this type of procedure? How would you answer that question for a patient?
Sure. So kind of two separate questions. First, will it change? And so what I tell patients is that from birth to about 18, 20, you're growing. So that's why your vision changes in that time period. Then it should be pretty stable once you're done growing from about 20 to mid 40s. And the reason it changes when you're in your mid 40s is that lens starts changing. It's not focusing. That's why people start having to hold stuff out and then wear reading glasses. And so that should be done changing if you don't replace the lens. That should be done kind of early 50s. And then kind of closer to 60s, 70s, your prescription can change again, because that lens is starting to develop cataract, which can shift your prescription. So once that lens is artificial, it's never going to change. You're not growing. So once you're fixed, you should be fixed forever, basically. The other question, maintenance, that lens it's acrylic, plastic. Basically, I tell patients is going to be around the earth hundreds of years. So if you outlive it, let me know your secret. But you don't have to worry about switching it out or anything. It's going to be around forever. The only thing that everybody has to do eventually, some within weeks, some within decades, is something called a YAG laser. And that what that is while we take out when we take out the natural lens, we leave the support structure, the bag, in place that we put the new lens in. And so we make a hole in the front of it to get the old one out, put the new one in. But the back of the bag is there, and that's to support the lens. Once it's scarred into place, it'll hold the lens in place, but sometimes it gets opaque. And when it does, we basically create a circular hole in the back of the bag. So it's like a donut, that there's nothing in the middle but the lens. And that typically improves your vision. If you notice, it's at one point right after surgery and then it declines. That's what's happening. Go see your doctor and they can do a YAG laser. You can drive yourself to that. It's about a 30-second procedure. It's just like the slit lamps that we use. Like, you just put your chin in there and it'll just be a light and it's over really quick.
Yeah, I tell patients it's the easiest thing we do for patients. No drops afterwards, and it's a one and done as well too on
Correct.
that.
Yep.
I can definitely tell you cataract surgery is miraculous in the fact that a 2 millimeter incision, no sutures, the implant rolls up and y'all unroll it inside the eye, and it's a permanent fix to so many lifelong issues for patients. So. Dr. Wright, I very much appreciate you joining our podcast today. So, any other comments?
No, I think those you had some great questions, and we kind of went over the majority of things. If anybody has questions, they can send them in, and we can answer them. But yeah, it was great. Thanks for having me.
Oh, absolutely. If you're not sure if you have cataracts or just have questions about it, we'll have information about how you can find more information or schedule an appointment as well. And I'd like to thank Val for helping us with editing this. So thank you, Val. And then follow, like, and subscribe as well. And stay tuned for our next podcast coming up. Thank you very much, Dr. Wright. I appreciate it.
Yeah, of
Thank
course.
you.
Thank you.
Bye bye.